Negative for intraepithelial lesion or malignancy NILM. Within the Bethesda system, cervical cytology findings are reported under the interpretation/results section. When a smear shows no cytological evidence of a squamous or glandular epithelial neoplasm, it is reported as negative for intraepithelial lesion or malignancy NILM. NILM should not be interpreted as a completely normal smear. It indicates only that the cytological findings do not meet the diagnostic criteria for an epithelial abnormality. A smear reported as NILM may still show a variety of non-neoplastic findings, provided there is no evidence of a premalignant or malignant lesion. Under the Bethesda system, these findings include reactive cellular changes associated with inflammation, typical repair, radiation, and intrauterine contraceptive devices, as well as non-neoplastic cellular variations such as atrophy, squamous metaplasia, tubal metaplasia, keratotic changes, and pregnancy-associated changes. Organisms may also be reported while the overall interpretation remains NILM. Reporting these associated findings is optional and does not alter the NILM category. In this lecture, we will discuss the non-neoplastic findings included under NILM, beginning with reactive cellular changes and then moving to non-neoplastic cellular variations. Organisms will be covered separately in the next lecture. Reactive cellular changes. The Bethesda system groups several benign epithelial alterations under the heading reactive cellular changes. These represent cellular responses to physiological or pathological stimuli rather than true epithelial neoplasia. Common causes include inflammation, tissue repair, radiation therapy, and intrauterine contraceptive devices. Although the cellular morphology may appear atypical, these changes remain within the NILM category because they do not satisfy the diagnostic criteria for squamous or glandular epithelial abnormalities. Despite their diverse causes, reactive cellular changes share several cytomorphological features. The nuclei may be enlarged, but they usually maintain smooth nuclear contours, finely distributed chromatin, and regular nuclear membranes. Nucleoli may become prominent, particularly in regenerating cells, but they remain regular in size and shape. Cellular cohesion and polarity are generally preserved, and the nuclear enlargement is usually proportional to the increase in cytoplasmic volume, maintaining a relatively low nuclear to cytoplasmic ratio. In contrast, epithelial abnormalities are characterized by disproportionately increased nuclear to cytoplasmic ratio, irregular nuclear membranes, coarse hyperchromatic chromatin, loss of polarity, and architectural disorganization. These features indicate that the atypia exceeds a reactive process and should prompt classification into the appropriate epithelial abnormality category rather than NILM. No single cytological feature is diagnostic in isolation. The overall cellular pattern determines the interpretation. With these general principles established, we can now examine each category of reactive cellular change individually, beginning with reactive cellular changes associated with inflammation. Reactive cellular changes associated with inflammation. Inflammation is the most common cause of reactive cellular changes in cervical cytology. Under the Bethesda system, reactive cellular changes associated with inflammation are reported within the NILM category because they represent a benign epithelial response rather than a premalignant or malignant process. These changes may involve both squamous and endocervical epithelial cells. Reactive epithelial cells typically show mild to moderate nuclear enlargement while maintaining smooth nuclear membranes, finely granular and evenly distributed chromatin, and preserved cellular polarity. The cytoplasm often remains abundant, so the nuclear to cytoplasmic ratio is preserved despite the increase in nuclear size. Prominent nucleoli may be present, particularly in regenerating cells, but they remain regular and should not be interpreted as evidence of malignancy. Binucleation, multinucleation, and cytoplasmic vacuolation may also be encountered as part of the reactive process. The inflammatory background usually contains increased neutrophils, lymphocytes, histiocytes, or mixed inflammatory cells depending on the underlying cause. It is important to remember that the presence of inflammation alone does not imply infection, and inflammatory changes should not be equated with an infectious etiology in the absence of identifiable organisms. Likewise, inflammation may obscure epithelial cells and, if more than 75% of the epithelial component is obscured, the specimen is considered unsatisfactory for evaluation according to Bethesda adequacy criteria. Within this category, the two epithelial populations encountered most frequently are reactive squamous cells and reactive endocervical cells, each with characteristic cytomorphological features and distinct diagnostic pitfalls. We will discuss these individually, beginning with reactive squamous cellular changes. Reactive squamous cellular changes. Reactive squamous cells are most commonly encountered in association with acute or chronic inflammation, trauma, instrumentation, infection, ulceration, and chemical irritation. Regardless of the underlying cause, the cytological changes represent a reactive epithelial response and remain within the NILM category as long as the atypia does not exceed the limits of a benign process. Reactive squamous cells typically exhibit mild to moderate nuclear enlargement, usually up to 1.5 to 2 times the size of a normal intermediate cell nucleus. The nuclei remain round to oval with smooth nuclear contours, finely granular and evenly distributed chromatin, and may contain one or more prominent but regular nucleoli. The cytoplasm is generally abundant with well-defined cell borders and may show cytoplasmic vacuolation, polychromasia, or ill-defined perinuclear clearing. Binucleation and multinucleation may also be present. The most important differential diagnosis is ASC-US. Although both reactive cells and ASC-US may demonstrate nuclear enlargement, reactive squamous cells retain uniform nuclear morphology, smooth nuclear membranes, fine chromatin, and a relatively low nuclear to cytoplasmic ratio. In contrast, ASC-US shows an increased nuclear to cytoplasmic ratio accompanied by subtle nuclear membrane irregularity, hyperchromasia, or chromatin abnormalities that cannot be explained by a reactive process alone. Another common pitfall is the misinterpretation of reactive perinuclear clearing as koilocytosis. Unlike the sharply defined perinuclear halo of ELS-AL, reactive halos are usually poorly defined and lack the associated nuclear atypia required for a diagnosis of HPV-related squamous intraepithelial lesion. Therefore, perinuclear clearing should never be interpreted in isolation without careful assessment of the accompanying nuclear features. Recognition of these preserved benign nuclear features allows reactive squamous changes to be distinguished from epithelial abnormalities while avoiding unnecessary overcalling of reactive smears as ASC, US, or ELS-AL. Reactive endocervical cellular changes. Reactive changes may also involve the endocervical epithelium, most commonly in association with inflammation, tissue repair, instrumentation, or hormonal influences. Although these cells often appear enlarged and atypical, they remain within the NILM category because their nuclear and architectural features are consistent with a benign reactive process. Reactive endocervical cells are usually arranged in flat sheets or strips, maintaining the characteristic honeycomb pattern when viewed on face and the picket fence or palisaded pattern when viewed laterally. Even when nuclear enlargement is present, the cells retain cohesive architecture and preserved polarity, which are among the most reliable indicators of a benign process. Individual cells show round to oval nuclei, smooth nuclear membranes, and finely distributed chromatin. The nuclei may be enlarged, sometimes up to 3 to 5 times their normal size, and prominent but regular nucleoli are common. Cytoplasmic mucin may be reduced, and multinucleation or mild pseudostratification may occasionally be seen. However, these changes occur in an orderly architectural pattern without significant nuclear pleomorphism. The principal differential diagnosis is atypical glandular cells and endocervical adenocarcinoma in situ. Reactive endocervical cells maintain flat cohesive sheets, preserved polarity, smooth nuclear contours, and fine chromatin, whereas glandular neoplasia is characterized by crowded three-dimensional groups, loss of polarity, coarse hyperchromatic chromatin, mitotic activity, and apoptosis. A particularly important feature favoring adenocarcinoma in situ is peripheral feathering, which is absent in reactive endocervical cells. Therefore, although reactive endocervical cells may exhibit striking nuclear enlargement and prominent nucleoli, preservation of architecture and nuclear uniformity remains the key feature supporting a benign reactive interpretation. Reactive cellular changes associated with repair. Tissue repair represents the regenerative response of the cervical epithelium following ulceration, inflammation, biopsy, cryotherapy, instrumentation, or other forms of epithelial injury. Under the Bethesda system, typical repair is reported as a reactive cellular change within the NILM category because it reflects epithelial regeneration rather than neoplasia. Reparative cells are characteristically arranged in flat, cohesive monolayer sheets with a streaming or taffy pole appearance. Despite active regeneration, cellular polarity and uniform nuclear spacing are preserved, producing an orderly architectural pattern. The cells exhibit abundant cytoplasm, vesicular nuclei with finely granular chromatin, and prominent, regular nucleoli reflecting increased protein synthesis during epithelial regeneration. Typical mitotic figures may be present, but atypical mitoses are absent. Neutrophils are frequently seen within or around the reparative cell groups, supporting a benign reparative process. The most important differential diagnosis is high-grade squamous intraepithelial lesion and invasive carcinoma. Although both repair and malignancy may show enlarged nuclei and prominent nucleoli, reparative cells remain cohesive and uniform, retain smooth nuclear membranes, and display fine, evenly distributed chromatin. In contrast, malignant lesions show loss of cohesion, marked nuclear pleomorphism, coarse hyperchromatic chromatin, irregular nuclear contours, dispersed atypical cells, and tumor diathesis. These features indicate that the atypia is no longer compatible with a benign reparative process. If the cytological atypia exceeds the expected spectrum of repair, such as nuclear crowding, significant pleomorphism, irregular chromatin, or isolated atypical cells, the findings should no longer be interpreted as NILM and must be classified under the appropriate epithelial abnormality category. Reactive cellular changes associated with radiation. Radiation therapy produces predictable cytological alterations in both squamous and glandular epithelial cells. Under the Bethesda system, these changes are reported as reactive cellular changes associated with radiation because they represent treatment-related cellular injury rather than persistent or recurrent malignancy. Accurate interpretation requires correlation with the patient's treatment history and the interval since radiotherapy. Radiation-induced cells characteristically show marked cellular and nuclear enlargement, often referred to as macrocytosis. Despite the enlarged nuclei, the nuclear to cytoplasmic ratio remains normal or low because cytoplasmic enlargement is proportional to nuclear enlargement. The nuclei demonstrate finely granular or smudged chromatin, while the cytoplasm may exhibit vacuolation, polychromasia, and degenerative change. Multinucleation and bizarre cellular forms may also be encountered but should be interpreted as treatment-related effects rather than evidence of malignancy. The principal differential diagnosis is persistent or recurrent carcinoma. Radiation effect favors a benign interpretation when the cells show preserved nuclear to cytoplasmic ratio, degenerative chromatin, absence of mitotic activity, and an appropriate clinical history of radiotherapy. In contrast, recurrent malignancy is characterized by disproportionately increased nuclear to cytoplasmic ratio, coarse viable chromatin, mitotic activity, tumor diathesis, and loss of normal cellular architecture. Therefore, although radiation-induced atypia may appear striking microscopically, recognition of its characteristic cytomorphology together with appropriate clinical correlation prevents misinterpretation as recurrent cervical malignancy. Reactive cellular changes associated with an intrauterine contraceptive device IUD. The presence of an intrauterine contraceptive device may induce characteristic reactive changes in both squamous and glandular epithelial cells. Under the Bethesda system, these are reported as reactive cellular changes associated with an intrauterine contraceptive device and remain within the NILM category because they represent a foreign body reaction rather than epithelial neoplasia. Two characteristic cytomorphological patterns may be encountered. The first consists of small cohesive clusters of endocervical or endometrial-type glandular cells containing abundant cytoplasm with large cytoplasmic vacuoles. The second consists of isolated vacuolated cells in which the cytoplasmic vacuole displaces the nucleus toward the cell periphery, producing a signet ring appearance. Associated findings may include reactive squamous changes, histiocytes, multinucleated giant cells, and calcific material. Actinomyces-like organisms, when present, are reported separately as associated organisms rather than as part of the reactive cellular changes. The principal differential diagnosis is glandular, epithelial atypia, and adenocarcinoma. Although IUD-associated cells may exhibit prominent cytoplasmic vacuolation and nuclear enlargement, the nuclei remain smooth, uniform, and cytologically bland, without the coarse chromatin, marked pleomorphism or architectural disorganization characteristic of glandular malignancy. Clinical correlation with a documented history of IUD use is therefore essential for accurate interpretation. Recognition of these characteristic treatment-related changes prevents overinterpretation of benign IUD-associated alterations as glandular epithelial abnormalities while ensuring that the findings are appropriately reported within the NILM category. Reactive cellular changes constitute an important subgroup of the negative for intraepithelial lesion or malignancy category in the Bethesda system. Although these cells may exhibit significant cytological alterations, they represent benign responses to inflammation, tissue repair, radiation, or intrauterine contraceptive devices and should not be overinterpreted as epithelial abnormalities. Accurate recognition depends on evaluating the overall cytomorphological pattern with particular attention to nuclear contours, chromatin, cellular polarity, and the nuclear to cytoplasmic ratio rather than relying on a single atypical feature. In the next lecture, we will continue the NILM category by discussing the non-neoplastic cellular variations recognized by the Bethesda system, including squamous metaplasia, atrophy, tubal metaplasia, keratotic changes, and pregnancy-associated changes, and understand how to distinguish these benign entities from their important cytological mimics.